So, welcome to today's YouTube flash revision on StudyMEDIC StudyMRCOG Part 2 January 2026. I am Dr. Avinash S S, mentor of StudyMEDIC StudyMRCOG group in the area of Biostatistics, and we will be doing the flash revision on study design, effect estimate, and diagnostic accuracy test. And this is the question. It will be in question and answer format for you easy revision, flash revision. So this is the question. A public health team wants to estimate the prevalence of the postpartum depression. That means they want to estimate the prevalence amongst the women who are attending the postnatal clinic in a large city. So this is the sample attending the postnatal clinics in large city. This is the sample, and they want to explore its association with. They want to know the breastfeeding practices and the socioeconomic status of the women. Data are collected at a single point in time using a structured questionnaire. So these are the hints, which is the most appropriate study design. And you can see the options here: case control, cohort, cross-sectional, randomized control trial, and ecological studies. These are the options. So the options here would be, since we are estimating the prevalence of the postpartum depression and the collection is at a single point in time. So what are they collecting? They are collecting the history of breastfeeding practices and also the history of socioeconomic status, the status of the socioeconomic status. They are collecting by the questionnaire. Okay, so the study is actually the cross-sectional survey or study. Now, what it is cross-sectional study, commonly referred to as survey. It measures the exposures as well as the outcome simultaneously at a single point in time. So you can see this is the sample women who are attending the postnatal clinic, and all the women who are attending the postnatal clinic, we ask them a structured questionnaire on breastfeeding practices and collect the details about socioeconomic status and see whether they are having postpartum depression or not. Okay, so this is the postpartum depression is the outcome we are collecting, and these are the exposures we are collecting the details on. Okay, so you can see the details are collected by questionnaires at a single point in time. So this is type of study design is called as cross-sectional survey, or simply called as survey. In the large population, it is called as census. Now, if we contrast it to this another question, here a researcher want to examine whether anemia, that is the HP percentage, is associated with low birth weight or not. To do that, what they are doing is, the sample is all women delivering in tertiary care hospital. This is the sample. All women who are delivering in tertiary care hospital over a 3-month period are assessed at the time of delivery. Now, what do they measure there is hemoglobin levels are measured and birth weight is also recorded. These are the two variables they measure. The outcomes are compared between anemic and non-anemic women. That means this is the two groups. They are classifying this into two groups with no further follow-up. What is the most appropriate study design? These are the examples, the options: descriptive and analytical cross-sectional study design, case control, prospective cohort, and randomized control trial. Now you can see here, this falls under as the analytical cross-sectional study design because the measures of exposure as well as outcome are collected simultaneously. But here, when you compare to survey, this has a comparison or a control group. So you can see all the women who are delivering in a tertiary care hospitals are the sample. In them, we are interviewing or asking a questionnaire or collecting the data by observation. What is the data we are collecting in all the women who are delivering in a tertiary care hospital? The data on hemoglobin we are collecting, hemoglobin values. And then what we do with this hemoglobin value is we are classifying them based on whether they are anemic or not anemic. Okay. In the same hemoglobin, whoever are reporting to this tertiary care hospital, in them we also collect the birth weight. We also collect the birth weight. But what we do is, after collection of the hemoglobin levels and the birth weight, we divide them into anemic and non-anemic after the collection. Okay. And in them, we compare the birth weight. That means we have a control here, which we divide after the collection. Okay. And then these are the anemic women. So this is a cross-sectional survey because at single point in time, we collect the exposure, that is the risk factor, as well as the outcome, birth weight, and can see whether it is low birth weight or not. Okay. So this is having a control group. Compared to the survey, it does not have a control group, and hence it is called as analytical cross-sectional study design, whereas survey is a descriptive cross-sectional study design without control. Okay, so it does not involve follow-up cross-sectional study design. So now next question, if you see the contrast to this, a researcher is investigating whether previous use of combined OC pills, oral contraceptive pills, is associated with venous thromboembolism. So this is the exposure and this is the venous thromboembolism is the outcome in women of reproductive age. So women who are diagnosed with venous thromboembolism are identified first. We can see women who are with VTE are identified from the hospital records, and a comparable group of women without VTE are selected. Comparable means matched group are selected. Past exposure to combined OCP use in this they are assessed, which is the most appropriate study design. Is it descriptive, analytical, case control, prospective, cohort, or randomized control trial? Now we will see what options amongst this is true. It is a case control study design because you can see it begins with the outcome status. That means cases who are with VTE are selected based on the diagnostic criteria, and they are matched with the controls who don't have VTE but are very similar to the cases. Okay, very similar to the cases in all other aspects. And they are called as matched controls, matched for age, gender, and other confounding variables. Then we look backward in time. This is the past time. We look backward in time. We ask the questions using a structured questionnaire or this one about whether these are using the OCP or not. We ask the questionnaire to both the cases as well as the controls whether they use OC pills or not. Now the odds of having the VTE in OC pills is A by B. Okay, whereas the odds of having in no VTE in OC pills used in no VTE is C by D. Okay, in controls. So the odds ratio is A by B by C by D. The odds of having VTE in having OCP use in VTE compared to the odds of having OCP use in without UTE becomes the odds ratio. So this is the case control study. We select the case, we select the control, matched control, then we further ask the questionnaires about the exposure. Multiple exposure can be collected by asking the questionnaire. Okay, so this is the case control study useful for long latent period cases or rare cases. Now the next question is, a researcher wants to study whether exposure to antenatal corticosteroids, this is the exposed group, is associated with reduced incidence of respiratory distress syndrome, and this is the outcome. Okay, so this is the exposure and this is the respiratory distress is the outcome in whom the sample is a preterm neonates, that is outcome in preterm neonates. Hospital maternity records from the past 5 years are reviewed. How they are collecting the data is using the hospital maternity records. And women who did not receive the antenatal corticosteroids are identified from the records. Who did receive the antenatal corticosteroids becomes the exposed group. Okay, and who did not receive the antenatal corticosteroid becomes the not exposed group or unexposed group. Okay, so you can classify them like that. And how they are collecting? They are collecting using the maternity records register. They are going back in time, which is the most appropriate study design. So these are the options. Is it retro? These are the options. And the answers is retrospective cohort study design. So you can see this is the present time. Okay, and in the we go back in time and use the medical record or registry to collect the details on antenatal corticosteroid administration. If they are administered, they are classified as exposed, and if the woman with no antenatal corticosteroid administration in the medical record registry with matched similar women, they are classified as unexposed. And these both exposed and unexposed are followed up in time from past to the present to see with the help of the medical record register whether the infants developed the respiratory distress syndrome or not. Similarly, we follow up also the unexposed, that is, they are not exposed to antenatal corticosteroids using the medical record registry to collect the data on the infants if they are having respiratory distress syndrome or not. So, okay, so now the relative risk we can calculate. The incidence of respiratory distress syndrome in those who are exposed to antenatal corticosteroid is, the number is A by A plus B. The incidence of respiratory distress syndrome in those who are not exposed to antenatal corticosteroids become C by, this is C and this is D, C by C plus D. The relative risk is incidence in exposed to incidence in unexposed can be calculated. You can see they are going back and then following up. So incidence and relative risk and attributable risk can be calculated here because it is temporal, temporality of cause comes first and the outcome comes next is established. It is one of the retrospective cohort study design. We will see what is prospective cohort study design now. A researcher aims to determine gestational diabetes mellitus whether it increases the risk of macrosomia. Pregnant women are recruited at 24 to 48 weeks gestation, screened for GDM. Now with the GDM and without GDM is what they know, and then they are followed until delivery to assess neonatal birth weight. Okay, so this is the outcome, and these are the exposed group, GDM. Without GDM are the unexposed group. Both they are following to see whether gestational diabetes mellitus increases the effect of macrosomia. Macrosomia is identified by the neonatal birth weight. What is the appropriate study design? So you can see here, it is the prospective cohort study design. You can see at present time, those with the GDM, that means these are the one who are exposed, are selected. Then similar to this with exposed, but not having GDM. Okay, they are similar in all other aspects, but they don't have GDM are also selected, and they becomes the unexposed groups. Okay, so in both we follow them up in time in future. Okay, not from backwards to present time. It is from the present time to future time. We follow them up and to see whether the neonates develop macrosomia or not using the neonatal birth weight. This is what we collect, neonatal birth weight, and we use that. Similarly, the controls, that is the unexposed people, are also followed up and to see whether they collect the data and see whether they develop macrosomia or not. Similarly, we calculate the incidence of macrosomia in GDM, A by A plus B divided by incidence of macrosomia without GDM is C by C plus D. The ratio becomes the relative risk. And you can see we are following them up in time in future. Okay, so multiple outcomes can be studied in this. It is good for establishing the etiology and causation. Even adverse drug effects can be studied using the prospective cohort study design. This is a classical example of prospective cohort study design. Okay, so this is begins with outcome status. So this is not this one. This is begins with the exposure. Prospective cohort study design begins with the exposure. Okay, and then it looks forward in time. It looks forward in time, not backward in time. Okay, and it is particularly useful for not rare outcomes. This is a contrasting between the case control. It is particularly useful for studying the rare exposure. It does not allow the estimation of odds ratio, but it allows the estimation of relative risk. This is the difference between case control and the cohort study design. Now, coming to the SBA type of questions about the study design, you can see that it's a lead in for each clinical scenario below. Select the single most appropriate study design from the list of options. Each option may be used once, more than once, or not at all. Which is the most appropriate study design is what you have to select. Now, this is the scenario. Women undergoing induction of labor are randomized to receive either drug A or drug B. So, there are two groups which are randomized and patients are recruited. They are unaware of which participants, that is the patients, are unaware of which drug they receive. But clinicians administering the drugs know which drug they are going to receive. So what type of study it is? It's case control. Because there is interventional, it cannot be case control or prospective or retrospective or cross-sectional study design. These are all observational study designs. Okay, so they are not interventional study design. Since there is an intervention to change the course of the outcome, it is usually interventional study designs. So, and these are the examples of the interventional study designs. Okay, now in this we have to find out what type of trial it is. Because here you can see participants are unaware, that means they are blinded, but clinicians are not. So it preferably is a single blinded randomized control trial because the randomization is present. So randomly allocated into two groups, intervention and non-intervention are two groups. Okay, randomization is present. And here the only participants are blinded. That means single blinding. Investigators, that is the clinicians, still know who are receiving drug, who are not. So it is a single blinded. Double blinded means clinicians also will not know. Whereas open labeled RCT means participants will also know, clinicians will also know whether they are receiving the drug of intention or the treatment of intervention or not. Now, coming to the another scenario, here pregnant women at the risk of preeclampsia are again they are randomized interventional study to receive low dose aspirin or placebo. These are the two groups. Neither the participants nor the clinicians nor the outcome assessor are aware of the group allocations. Nobody knows whether they are receiving low dose aspirin or placebo. Both are given in a similar sachet. Okay, how to know whether they are receiving low dose aspirin is the coding is done. Who receives or not, it will not be known to participants or to the assessors. Now that means two people are blinded here. It is called as double blinded. Who are blinded? Participants are also blinded regarding the treatment allocation, and clinicians are also blinded. Okay, so outcome assessors are also blinded. This is the gold standard for the reducing the investigators bias. Okay, so it cannot be single blind or open label. Now we will see another example. Women with heavy menstrual bleeding are randomized to receive either a levonorgestrel intrauterine system or oral tranexamic acid. Both participants and clinicians are aware of the treatment. So they know what they are receiving, whether they are receiving intrauterine system or whether they are receiving, because it cannot be blinded. So if you are putting IUD, they know they are putting IUD. If you are giving oral drug, they know they are giving oral drug. So nobody can be blinded here. In such a case, it is called as the open label RCT. Randomization is done, so randomized RCT, no blinding at any level. It is common when blinding is impractical. For example, when you are giving surgery or procedures, medical treatment like procedures, like the previous example. It is still an RCT, not an observational, because intervention of to change the course of the outcome is still given. Now another scenario, a maternity unit introduces a new protocol for active management of the third stage of labor. Rates of postpartum hemorrhage before and after the intervention are compared with no randomization. That means there is no randomization, but they are divided into two groups. They are divided into two groups, and intervention is also there. Intervention is also there. So this is a quasi-experimental study design. Intervention is there, but there is no randomization. They are allotted to based on convenience, and hence it is called as quasi-experimental. Interventional study designs are called as experimental study designs or interventional. This is quasi-experimental because it is convenience sampling. It is not an RCT. RCT is an example for randomized interventional study design. This is a non-randomized quasi-experimental study design. However, there is higher risk of confounding is seen in these experiments. So another date is national data are analyzed to compare maternal mortality ratios across countries with the different cesarean section rates using country level statistics only. Here you can see the maternal mortality rate is collected, but the whole country level it is collected, and it is compared with the different cesarean section rates using the country level statistics by the collection of the data. Here it is called as ecological study because data is analyzed at the population or group level, country A, country B, city A, city B, like that. No individual exposure or outcome linkage can be established here. It is prone to what is called as ecological fallacy. In some country, the association may be found, it may not be found. This is called as ecological study design. Okay. Now the another is researchers conduct a structured literature research, applied predefined inclusion and exclusion criteria, and they critically appraise all studies evaluating the magnesium sulfate for eclampsia without statistically pooling the results. Here they are collecting the individual studies and they are not doing any analysis, and this is called as a systematic review. It is a structured research with explicit methodology and we appraise it. There is no statistical pooling of the results. There is no analysis and there is no estimation of the overall estimate. You can see that all systematic review need not require meta-analysis. Now, what about meta-analysis? This is an example. Here, they do the systematic research, but they statistically combine the results from multiple randomized control trials and they generate a pooled effect estimate for antenatal corticosteroids in preventing neonatal respiratory distress syndrome or not. So, multiple studies are collected and they are represented and they are analyzed to find out what is called as the statistical pooling to estimate overall estimate of all that study together, overall estimate of all the studies done together, and this is called as meta-analysis. and it is not, the review is done and then analysis is done. So you can see all meta-analysis are systematic reviews, but all systematic reviews need not include meta-analysis. All meta-analysis include systematic review, they have to be done, but all systematic reviews need not include a meta-analysis. Okay, and the representation will be in the forest plot. So that is about the study design. This is the classification of the study design. You can see the examples here. Okay, if it is the intervention is there, it is called as interventional study design, and they are classified into randomized, interventional, and non-randomized quasi-experimental study design. If no intervention, it is called as observational study design. It is classified into descriptive observational study design, that is a survey, and analytical observational study design, and which are examples are cross-sectional study designs, case control study, retrospective study, and prospective cohort study designs. So this is the hierarchy of the evidence: meta-analysis followed by RCT followed by cohort, case control, cross-sectional. The highest is the hierarchy of evidence is for meta-analysis. So this is about the study design. Okay. Now let us see the calculation of the effect estimates. Now this is the question. You can see the hospital-based study was conducted to assess the association between gestational diabetes and postpartum hemorrhage. 100 women who developed PPH and 100 women who did not develop PPH were included. 40 of the PPH had GDM and 80 of the women without PPH did not have GDM. What is the odds ratio for developing PPH in women with GDM? So you can see 100 women who developed PPH. So these are the 100 women who developed PPH. Okay. And 100 women who did not develop PPH. 100 women did not develop PPH. 40 of those with PPH had GDM, and 80 of the women without PPH did not have GDM. Okay. So this is how we fill the data. The rest of the data can be filled like this. The remaining is 60 and remaining is 20 here. So how to calculate the odds ratio is this: odds of PPH, odds of GDM in PPH is 40 by 60, and odds of GDM in without PPH is 20 by 80, and the odds ratio is division of this. So you can see the division of this yields what is called as 40 by 60 by 60 by 20 by 80, and the division will yield 2.67. That means women with gestational diabetes have higher times 2.67 higher times higher odds in developing PPH compared to women. Even you can do like this: odds of PPH in GDM 40 by 20, odds of PPH without GDM 60 by 80. All will give the same values. Either A by B divided by C by D or A by C divided by B by D. Everything will give the same values. Now the next question is a prospective cohort study design conducted to determine whether obesity is present. There are around 1,000 total women were selected. Amongst those, 400 obese women are there, 400 obese women, and 600 non-obese women are there. In 80 developed, amongst the obese women, 80 developed eclampsia, and amongst the non-obese, 60 developed eclampsia. Now we have to fill the 400 minus 80 is 320, 600 minus 60 is 540. So this is how we fill this. Now we have to calculate the relative risk, means incidence of preeclampsia in obese women is 80 by 400. That means 80 divided by 400 becomes the incidence. A by A plus B. A by A plus B. Incidence of preeclampsia in unexposed, IU. So this is IE, and IU is 60 by 600. 60 by 600. So the relative risk is IU by IE. The relative risk comes to around 2. That means obese pregnant women have twice the risk of developing preeclampsia compared to non-obese women. Now, similar study here, the question is around 800 women are there. Aspirin group is 400, and placebo group is also 400. In aspirin group, 40 developed preeclampsia. In placebo group, 80 developed preeclampsia. So the remaining is 360 in aspirin group, and the remaining here is 320 in the non-placebo group. They want to calculate the absolute risk reduction. Absolute risk reduction is IE minus IU, incidence in unexposed minus incidence in exposed. Now incidence of preeclampsia in exposed is 40 by 400. Incidence of preeclampsia in placebo group is 80 by 400. So this is the unexposed and this is the exposed group. Now we have to minus the unexposed minus exposed, and it will come to as 0.1. That means low dose aspirin reduces the risk by 10% in high risk pregnant women. This is the formula, and this is the interpretation. Now the next one is, there are around 600 women randomly allocated into two groups. In corticosteroid groups, and this is not aspirin group, let us say this is a corticosteroid group, around 300 women, and in control group around 300 women. So 13 neonates developed, this is not preeclampsia, this is RDS and no RDS. Okay, 13 neonates developed RDS, and 16 neonates in control group developed RDS. So the remaining here is incidence in. Now they want to calculate number needed to treat. Number needed to treat is 1 by absolute risk reduction. Absolute risk reduction is IU minus IE. So this is the IE. That is 30 by 300. 60 by 300 is the IU. So this is IE, incidence in exposed, similar to previous formula. And incidence in unexposed is 60 by 300. Okay. So when we calculate this, it will come to around 10. That means 10 women need to receive antenatal corticosteroid to prevent one additional case, of neonatal respiratory distress syndrome. Now there are, here you can see 1000 women are there. 500 women are in aspirin group and 500 women are in control group. 50 developed preeclampsia and 100 developed preeclampsia in control group. They want to find out relative risk reduction. The formula of relative risk reduction is IU minus IE by IU. That means compared to the unexposed, what is the reduction in the outcome? Compared to the unexposed, what is the reduction in the outcome? That is absolute risk reduction by incidence in unexposed. When you put the formula, you get it is as 0.5. That means low dose aspirin reduces the relative risk by 50%. Low dose aspirin will reduce the risk by 50%. That is called as relative risk reduction. Now similarly, a cohort study was done. There were 500 anemic women and 500 non-anemic women. 75 delivered preterm in anemic and only 25 delivered in non-anemic women. So they want to see attributable risk. Here the exposure is increasing the risk. So attributable risk is incidence of exposed minus incidence in unexposed. Incidence exposed is 75 by 500, unexposed is 25 by 500. When we do that, we get it as 0.1. That means 10% of the preterm birth among anemic women can be attributable to anemia itself, potentially preventable if anemia were eliminated. That is attributable risk increase. When incidence in exposed is more, we calculate this IE minus IU. Now the randomized control trial, if in the drug group we have 400 and in the standard care group we have 400. In the drug group 40 developed fever and in the standard care 20 developed fever. They want to see how much is the number needed to harm. Number needed to harm is 1 divided by absolute risk increase. Absolute risk increase is IE minus IU. Here IE is 40 by 400. IU is incidence unexposed 20 by 480. So when we calculate, it comes to around 20. That means for every 20 women treated with the new drug, one additional woman will develop postpartum fever. That is the number needed to treat. Okay. Now let us see the diagnostic accuracy tests. Let us see the diagnostic accuracy test. A new rapid test is introduced. How to perform preeclampsia. Okay. In 400 women who are presenting with hypertension after 40. That means total is 400 women. Okay. The test was evaluated against the gold standard diagnosis among 200 women who truly had preeclampsia. That means disease is present in 200 women. The test was positive in 180 women and negative in 20 women. Okay. Now you can see 180 women are positive, true positive, 20 are false negative. Specificity was 90%. What is the remaining here? Out of 200, another 200 are remaining. Specificity means that is true negative by true negative plus false positive. That is the specificity. That is 0.9% means true negative is 90% of 200. That is around 180. The remaining is 20. So that is the false positive now. Once we fill all this, we can calculate the sensitivity as true positive divided by true positive plus false negative. This is the sensitivity and this is the specificity. So once we fill the 2 by 2 table, we can calculate this as true positive by true positive plus false negatives. That is 180 by 200 equal to 90%. Okay, that means out of those who are having the disease, how many are tested positive? If it is 100% sensitive and it tests positive, then we can definitely ruling out the disease can be done. If test is negative, we can definitely rule out the disease. If it is 100% sensitive and it turns negative, 100% sensitive and turns negative, it does not depend on prevalence. Now, similarly, among the 200 women who did not have gestational diabetes, screening test was negative in 270 women. Screening test was negative in 270 women, and screening test was positive in 30 women. Okay, so that means we are not filling it here. We already they are giving among the 300 who are having not having the condition 300. Here they are not giving the data about the total data. They have just given 300 those who are not having the disease, and 270 women test negative and 30 women test positive. So they already given the false positive and true negative values here. All you have to do is specificity means true negative divided by true negative plus false positive. So you can see it is the true negative divided by true negative divided by plus false positive. Amongst those in which disease is absent, how many are tested negative becomes the specificity. So that is 270 by 300 is 90%. Okay, the remaining you can fill using the if there are 400, the remaining, this is not 400. So the remaining you can fill based on the other datas. Okay. Now the next question is a rapid bedside test is done. Here among 150 women who tested positive, 90 women truly had postpartum endometriosis. Means 150 women tested positive, 90 women truly had postpartum endometriosis. Disease is present, while 60 women did not have the condition. Okay, 60 women did not have the condition. This is false positive. Okay, what is the positive predictive value? Positive predictive value is amongst those who are tested positive, how many have the disease? That means true positive by true positive plus false positive. So once we fill this data, we can clearly find out the that is positive predictive value is true positive by true false positive. It is 90 by 150. 90 by 150 is 60%. So that means the positive predictive value. It is affected by the prevalence. More is the prevalence, more is the positive predictive value. Now another data among 250 women who tested negative. That means 250 women are tested negative. 240 women truly did not have the chorioamnionitis. 240 is true negative. 10 are false negative. What is the negative predictive value? Negative predictive value is amongst those who are tested negative, how many do not have condition? That is true negative by true negative plus false negative. That is the negative value. That is 240 by 250. And that comes to around 0.96 is the negative predictive value. Okay. So it is highly dependent on disease prevalence. It is inversely related to disease prevalence, unlike positive prevalence, positive predictive value. Okay. So screening test in obstetrics often aim for high negative predictive value and high sensitivity Okay. So that is about the negative predictive value. Now let us see how to calculate the negative likelihood ratio. Among women who truly had ectopic pregnancy, the test was positive in 90 and negative in 10. That means who truly had ectopic means these people 90 are truly positive, and that is true positive, and negative in 10. So total disease present is 100. Who did not have ectopic the pregnancy, the test was positive in 30, false positive, and negative in 170, true negative, and total is 200. Okay. Now they want to calculate a negative likelihood ratio. Negative likelihood ratio is 1 minus sensitivity by specificity. Sensitivity is true positive rate. 1 minus sensitivity is false negative rate. Divided by specificity is nothing but true negative rate. Amongst those who are not having condition tested, having condition tested negative compared to not having condition tested negative is the negative likelihood ratio. So once you do apply the formula, you need to calculate sensitivity. Sensitivity it is 90 by 100. Specificity is 170 by 200. And when you apply to the formula 1 minus sensitivity by specificity, you get this answer 0.12. Okay. So how much does a negative test reduce the probability of the disease is the negative likelihood ratio. It is usually less than 1. Less than 0.1 is a good, strongly rules out good diagnostic accuracy. More than 0.5 is a poor diagnostic value. Okay. Unlike positive predictive value, negative predictive value, likelihood ratios are not affected by disease prevalence. This you have to understand. Okay. Now here formula is given. A diagnostic test is evaluated. Here, what they have given is sensitivity of the test is given 20%, specificity of the test is given 90%, and specificity of the test is 85%, sensitivity of the test is 90%, and prevalence of ectopic pregnancy is 20%. They are given this. What is the pre-test probability? They will ask. Pre-test probability is nothing but the first question. The pre-test probability is nothing but the prevalence. What the prevalence they are given? 20%. 20% means 0.2 is the pre-test probability. The next question is, what is the pre-test odds? The formula for pre-test odds is pre-test probability divided by 1 minus pre-test probability. That means 0.2 divided by 1 minus 0.2, that is 0.8. The pre-test odd is 25% or 0.25. Okay. So this is how we calculate the pre-test probability and pre-test odds. Now what is positive likelihood ratio? The likelihood ratio, we know it is sensitivity divided by 1 minus specificity. That is, likelihood ratio is positive is true positive rate divided by 1 minus true negative rate is false positive rate. Amongst those who are tested having the condition and tested positive compared to among those who are not having the condition tested positive, that is the likelihood ratio. They already given 90% is sensitivity, 85% is specificity. Put into formula, we get the likelihood ratio as 6. More than 1 is good, more than 10 is very good diagnostic accuracy. Moderate accuracy is for 5 to 10. Now, what is post-test odds? The formula is a little different. Post-test odds is pre-test odds multiplied by the positive likelihood ratio. Okay, the pre-test odds we calculated as 0.25, likelihood ratio we calculated as 6, and now we get post-test odds as 1.5 times. Now, what is the post-test probability? To convert odds to probability, this is the formula. Probability is post-test odds or whatever odds divided by 1 plus odds. Whereas odds is equal to probability by 1 minus probability. Probability is odds by 1 plus odds. So pre-test post-test odds is 1.5 divided by 2.5, that is 1 plus 2.5, 1.5 is 0.6. You can see 60%. So what has happened? The pre-test probability after doing the test has increased to 60%. Prevalence, okay, increased to 60%. The pre-test odd was 0.25, then the likelihood ratio, then the post-test odds, and then the post-test probability. This is how the chain will follow in the diagnostic accuracy test. So today we discussed around 15 SBS and 15 AMQs in the topics of the diagnostic accuracy, effect estimate, and study design for the flash division purpose. Wherever you are seeing that the data is too much or the information is too much, you can pause and view it. And wherever you can the information is fast, you can slow down the YouTube video and view it. And thank you for watching this. Do subscribe this channel. Thank you.